Hello, welcome to part 2 of the psychology Q&A. My name's Ro, I'm a clinical psychologist from Sydney, Australia, and last video I did a Q&A that was all about stuff for people who want to become psych students, people who want to become psychologists, questions around where I am right now, my pathway, how I got there. Today I'm going to be concentrating on all the questions I got that were relating to people who are already in masters or already practicing or thinking about practicing a bit more in depth. As always, I post all of these kind of call outs for Q&As on my Instagram, which is @_the psych diaries. Give it a follow if you want to ever submit a question, DM me, that kind of stuff. Anytime I post a video, I'll go onto Instagram and I'll ask people like any questions, that kind of thing. All of the questions are timestamped below, so just click the description box. And like I said last video, a lot of the questions that I was asked, I've answered in previous videos, much better quality. I sat down and did the whole video on just one question. And so if you go to the first video, I'll outline exactly which video answers which questions and I'll have links to all of the videos. Let's hop into it. So question 1 is, what is the difference between working with individuals in therapy versus working in group therapy? Such a fun question. I've worked with both. I have done individual therapy with group work. I've run a Cool Kids for Anxiety group, which is for children and their parents. And then for the adult group, I've run the DBT or dialectical behavior therapy group. Yeah, it is really different. First of all, I really love the mix of it. Having just back-to-back 1-hour clients can get kind of monotonous sometimes. When I was working full-time private practice, I made sure that I was doing group work in addition to that. Each clinic and workplace will have different, like whether they run groups or not, and so I recommend you, if you want that variety, to look for a job where they have the ability to do individual and group. First of all, with individual therapy, you are really getting to know one person and their story, what has happened to them in the past, what's brought them to this place, and you're trying to understand their specific pattern. You're really trying to deep dive and problem solve and tailor the therapy to them. With group therapy, often it's a manualized treatment, and so there is a session 1, this is what you go through, this is the homework, session 2, this is what you go through. It's manualized because the research and the evidence is around this specific structure, and also there's so many people, you can't tailor it to each individual person. People get selected for the group, so for instance for dialectical behavior therapy, it was people with borderline personality disorder or traits. They come to group once a week and they also have their individual therapist. Groups are more for dispensing the therapy or strategies or information in a way where 1 hour hits maybe 8 people as opposed to one person in individual. So it's a better use of your time. 2, people actually get to learn from each other, and that's the most fun part of being in a group. It's that all of the different participants are experiencing similar issues, and so you get to say, you know, this week I tried this and it was so great, and someone else going, oh wow, that I really relate to that. Get this kind of supportive environment where everyone kind of understands where everyone else is coming from. With groups as well, you've got much more of a sense of camaraderie. People are kind of following up with each other. In my Cool Kids group, we had different people pairing up and practicing their homework and their exposure tasks together. With group as well, you've got group dynamics to deal with. So especially for certain types of groups, you're gonna have people who are a little bit tricky to deal with each other. In my DBT group, these are clients with complex emotion dysregulation, and a lot of them have gone through some really traumatic history, and it's tricky to hear other people who might be going through or are currently in an abusive relationship and that kind of thing. And so you often see that there are group processes where some people don't rub each other the right way. Someone says something, someone gets triggered, they're yelling at them. That's part of, I don't want to say like fun, but it's part of the process of being a group facilitator, is how to identify stuff like that, how to problem solve stuff like that. In the DBT group, we always had 2 facilitators. So if something like that went on, one person kept delivering and the other one helped people outside. Or it could be that, you know, something's really triggering and someone starts feeling like they need to self-harm. So we kind of remove that person and work with them individually. Group processes are really interesting. I'm still learning how to deal with them, and they're going to be different for every type of group, whether it's an anxiety group or it's a panic group or it's a emotion regulation group or it's a drug and alcohol group. Yeah, so that's why I think group work is so interesting. However, the bread and butter of most psychologists is doing individual therapy. Next question is, if you're already studying, how do you get paid for your placements? This one's tricky. So at UCID, my master's program, I didn't get paid for any of the placements, and that's because the majority were in New South Wales Health. They're not paying you because you're getting all of this free supervision and training and you're working in the hospital, and really, really rarely you might. So for instance, my friend is studying at Charles Sturt right now. She's doing an online master's. Her one is actually paying her like a small fee per client that she sees. However, her placement is in a private practice clinic, not in a public health hospital system. And generally placements with big institutions, public health settings, are kind of more valuable work experience because they're under New South Wales Health, and to say that you've worked within a public setting is really great experience in the future if you want to go for it again. All I want to say is don't prepare to get paid. Like, it's really rare that I ever hear of anyone getting placements. Are for us to learn skills, and part of the payment would also mean that you have to do insurance and all of that kind of jazz. To be completely honest, I think I really wasn't very confident in my skills, and so I kind of almost felt better that I was providing it and not getting money for it yet. But the way that I made money during my master's program was I actually just worked a part-time job. I got my money through other means outside of my master's. How did I decide what treatment modality to specialize in? For those who don't know, a treatment modality is what type of treatment do you choose? As a psychologist, the main one that you get taught in Australia is cognitive behavioural therapy. Gold standard, really well researched, heaps of great evidence around cognitive behavioural therapy for kind of acute anxiety and low mood. CBT is a really great grounding to have because for most people who walk through the clinic, it is helpful to learn to be more aware of your thoughts and how they affect your feelings and the types of behavioural patterns that could be kind of exacerbating what they're going through. However, as I kind of got more and more into it, I started doing extra training, and every year you have to do extra training as a psychologist. And the next modality that I picked up was acceptance commitment therapy, which has its roots in like Eastern philosophy. It talks a bit more about, instead of diving into the thoughts and figuring out what's wrong with the thought and how our thoughts are biased, it talks about how a lot of the things that we're worried about, things like, am I fitting in? Is my future gonna work out? People like me? A lot of those are just part of who we are as human. In ACT, or acceptance commitment therapy, we talk about how to have the thoughts in the background, but how to actually engage meaningfully in things that are important to us. And it talks about values, and it talks about how to kind of diffuse or separate ourselves or take a step back from that kind of running monkey brain. The one I'm really deep diving in now is schema therapy or schema mode therapy. This is a really good modality if you're working a lot with trauma. We do a lot of imagery work. I'm doing a lot more stuff in people's kind of early history. People who have gone through quite a lot, I'm finding a lot of schema work really helpful. How to decide what to specialize in is you're not really given a choice at first. You're just given CBT and you're given a little bit of everything else. I also learned DBT. As you go along, depending on what types of clients you're working with, depending on what you personally align with. So certain people just say like, I hate CBT, I just can't do it. I'm a psychodynamic therapist. You will get kind of a touch of all the different types of therapies in your training, and you'll just figure out which ones you like. Give all of them a go, see which ones you connect with the most, and as you go on, you will get different types of training. So in terms of training as a psychologist, there's a couple of different websites. I don't know all of them, but I think it's called Schema Therapy Training Online. I'll link them all below actually. This is where I did all of my schema training. You can do it in person or you can do it online by Rob Brockman and Hayes. I'm so sorry, I forgot. But they are the like big schema people in Australia. Really great program. And then I did ACT online as well with Russ Harris, who's the one who wrote The Happiness Trap. Really fun training as well. So I did those online and I really recommend both. I have a question around how many sessions it took until you understand a patient or kind of get to know the patient. So the way that I work, I think it's very different for a lot of people. But the way that I work is the first session is all about assessment. My only goal is just to know more about how they're doing now, what brought them here, what their history is, family history, all of the different factors that could be going together to influence what they're currently experiencing. And in the session after that, I typically do a formulation, which is where I actually write it out on a piece of paper. You piece together this type of experience growing up or with this type of role in your family. It makes a lot of sense why you think in this way and you have these core beliefs, and then that might lead to this type of behavior, which is triggered by this recent family stressor. So 2 sessions is what I kind of need in order to both assess and then also sit down with the client and explain what could be going on for them. And then we launch into the treatment. However, learning about the client is like forever. Like, how do you know about someone's life story in the first hour or two? Like, there is no way. Every single session we are learning more about the client. They're adding more details in. I also want to give people useful stuff, so we're not sitting there for 6 sessions just learning about each other. As we go on, if we learn really big new things, we update the formulation. Okay, my battery died. I'm not exactly sure where I left off. As you go along, you'll get to know the client more. What is really interesting is often you come in with one goal, and then as people get more comfortable with you, sometimes things that they maybe didn't disclose or they were embarrassed to or they weren't aware of yet. The main thing is just don't get too stuck on who your client is and what they're about and what our treatment is. It is always flexible. Really try and adapt what they're telling you into the way that you do your therapy. How to build rapport with a client. This one is a huge question. So a couple of things. First of all, I think you are a psychologist because of you. Like, really, oops, ambulance brake. You are a psychologist because of you and your personality, and the way that I am with clients is very different to how a colleague of mine is going to be with a client, and there is no right way to be a psychologist. I think earlier on you really want to do the right thing, and so you're thinking about, how do I be nice to someone, or how do I build rapport, what are the rules, but really think about who you are. And if you feel comfortable in session, all I would say is like have a certain mindset, which is I want to have this person feel supported when they leave the session. I want them to feel understood. I want them to feel like I get what's going on and that I am someone who can help them. And so we want to be capable. We want to be providing evidence-based research. We want to be telling the client what the plan is so they know what they're going through and they're not just kind of being dragged along, kind of feeling a bit lost. Coming in with those types of intentions, how it actually happens is really different. So for instance, I get a little bit jokey with clients sometimes, with some of them that I'm quite comfortable with, or, they're at a certain age group or whatever, I'm swearing, I'll slip in stuff with like little anecdotes which are helping to illustrate a point. It's pretty fun. Like I'm like this, I'm just how I feel like most of the time. However, with other clients who maybe they come in and they have this really depressed affect and they're looking really flat, you want to try and mold yourself a little bit, match their energy and so maybe what they need at that time. If you want to become a psychologist, I think a lot of you guys are really empathetic. You pick up signals from other people really well. As you go on, you'll learn and you'll practice more and more what it's like to pick up on people's body signals and attune to that. I could be behaving completely different in one session to another session, and they're both different ways of just attuning to the client. Think less about what you have to do, like, oh, I have to make jokes, or I have to say this, or I have to do this when they're, telling me something, and think more about your intentions going and how you want them to feel when they leave your session. And the way you do it is actually, just as an example, my supervisor, who is an older male, you would have met him in one of my Day in the Psychologist videos, his name is Peter. He has a very different personality to me. So if I was trying to enact Peter, fun, jokey, Australian dude, like I would really fall flat on my face. But you be yourself and you bring a little bit of genuineness and authenticity to the sessions, and that'll make the client feel more comfortable than if you're trying to role play someone else. When does the imposter syndrome go away and how to help with that? Look, I think this is such a huge question. I might even do a specialized video on it. Preliminary thoughts are, imposter syndrome is actually a really helpful trait to have early on. If we come into psychology and mental health in general and think, I'm the expert, I've got this, don't you worry about me, I don't think that's necessarily good for your clients. We always want to be approaching a little bit with this sense of like, I don't know everything about you, I don't know everything about the treatment and the evidence and what's going to be appropriate for you. And so having a little bit of that is helpful. If, however, we have so much of it that we're doubting ourselves, we're not pushing therapy because we're nervous that it's going to offend people, if we've kind of given up and gone, I'm just not good at this, then that's getting in the way. Let's think about like a CBT kind of triangle, like how do our thoughts affect how we behave? If I think that I'm a terrible psychologist, do I go into sessions confident and, give clients this energy and this kind of security of knowing that I've got it? Or do I go into sessions kind of like, oh, like I guess you could try this kind of meek, because clients can feel our energy, and if I have a pilot who's flying my plane, or if I have a doctor and they're acting really nervous, I'm gonna start freaking out too. Sometimes, even if I'm not exactly sure what's going on, maybe there's just a lot of stuff going on, I will still act confident. We need to at least have some level of confidence in our abilities. Several things that we can tell ourselves are, we have been trained in this. You did all of your study on the most up-to-date evidence-based interventions for their particular mental health struggle or issue. It is not about life experience or who you are, your age, what you've gone through in life. If you haven't gone through what they have gone through, that is okay. You don't have to have experienced psychosis or depression or had a panic attack in order to help someone who has experienced those things, just like doctors don't have to have had cancer or obesity or be smoking to help treat people in those things. We are experts in understanding the antecedents to certain mental health difficulties and knowing the evidence-based treatment to treat it. You are the expert here. Lean into that. You've got this. And if you don't got it, then do some more research. Go to a textbook, go and talk to your supervisor and upskill. This is not about naturally knowing that you're a good psychologist and you're just kind of born with it and they're so good and I'm not good. Go into it with this growth mindset of no one's born a good psychologist. It is all about training and practice and knowing that you're not going to be. So actually my third tip is you're going to be shit. Just accept that you're going to be shit. And this is one of the best pieces of advice that my supervisor gave me. How are we meant to be good at this job? It's huge. Being able to help with someone's mental health that has so many different factors involved with it. I'm getting more confident now and I'm 4 years into my practice and I feel really good most of the time, but there's still sessions where I come out and I screwed that up. I have no idea if I said the right thing. I feel like they were disengaged. This is a lifelong practice. When you first start, you are meant to be bad. No one expects an Olympic high diver to just be great at it when they first get started. Don't expect as a psychologist you're going to be great at it when you first start. And so give yourself that compassion. It's okay. Every single psychologist has gone through that early stage and they're not very good. A good psychologist is someone says, that wasn't very good. What was it about that session that wasn't very good? How can I actually develop myself? Actually going home and workshopping, how can I approach that differently if this comes up again? If you're learning from your mistakes, that is the best thing that you can be doing. Last tip that I can think of off the top of my head is when you walk into a doctor's office, people just assume that you've got a level of competence, and so don't feel like you need to constantly justify yourself. They are not aware of all of the self-doubt and imposter stuff going on in your head. A lot of them are actually just absorbed in I need some help. Can you help me? And they're not really thinking so much about you. So take the attention off you. And if you can really spend most of your energy and your attention just on the other person and less on am I doing this right? And how am I feeling about this? And what if they hate me? You're going to make a much better clinician because it is about them and it's not about us. It makes us better clinicians, it reduces the anxiety, and also patients will feel like we're present in the session as opposed to our body is here and our brain is I'm struggling, I'm not doing well. I say all of that as if I don't experience it. I constantly experience it. It's just part of the practice. Psychologists and psychology students are often people who are a little bit more anxious, perfectionistic, and so it's part of the process, I think. Last question I'm going to end on is child versus adult work. I have worked in both. Child work, I worked at a clinic where it was 0 to 18, and the way that I like to work is actually mostly with the parents because kids are lovely and it's so fun to work with them. You get to play games, it's dynamic, you get to be a bit more down to earth. My big aim when I was working in a child practice was empowering parents, giving them the skills, giving them the knowledge so that they can help their children, as opposed to I'm now a drop-off service where every week for 2 years you give your child to me for an hour and I play with them and do therapy with them and the parents are disengaged. When children are young, it is all about the family system. Personally, I'm so on board with learning about attachment, circle of security, knowing about the impact of how our parents associate with child emotion, how we speak about emotion, how do we talk to each other, how do we fight and repair. I feel like that is such a core part of the therapy. Even though I was doing child therapy, I was mainly doing adult therapy for parents on children behavior and emotion. In some ways it was trickier because I'd have to work with the child, get to know the child and the parent, and often their OT, their speech therapist, their school teacher, their principal, their learning support officer, and you might have multiple siblings and you might have mum and dad. There were a lot of people involved. But it was fun, it was dynamic. Often the change happens quicker because you know, stuff has just started, parents are really engaged. On the other hand, I almost feel like adult work is more grounding. Like it's just you, another adult, they have self-referred themselves and so they're motivated, which is a great plus. Some kids don't want to be there. Adults also have adult issues, and so you're also thinking a lot about different types of stuff. You're doing a lot more kind of detective work for when did that first start, or why do you think you started seeing the world in that way, or why did you think you have to behave in that way when someone says no to you. However, you're not working out so much on those dynamics. You don't have to think about in the session what it's like to talk to mum and dad when they're fighting at each other. You only have one person. You spend all your energy on that one person. You're working a lot more with diagnoses. Social anxiety disorder, bipolar disorder, schizophrenia, major depressive disorder, because often there's a lot more like kind of adult diagnoses than children diagnoses. For children, we're mainly working in like big emotions, emotion dysregulation, or big behaviors. They're hitting people, they're upset, we're working with like anxiety. It's a little bit more general. Some of the more kind of serious schizophrenia, psychosis, that kind of stuff is where you work more with adults. In saying that though, like there are children eating disorder clinics, there are adult clinics or like adult patients where I just work on like they're stressed at work. So there is a whole range. It's a bit of a spectrum. Yeah, I could talk about this also for a long time. If you guys have extra questions or ones that you really feel like you want me to deep dive into, let me know below. Just give me a comment or kind of answer the next time I put up one of those Insta Q&As. I really would love to reply to every DM, but unfortunately there's just so many that I don't get through to all of them. And so I will try and address it so everyone can get the same information. Thank you guys so much for tuning in. All the best. It's so cool to know that the viewership now isn't just psychology students, it's also people who are practicing, and best of luck in your practice or your studies. Thanks for tuning in. Bye.